Okay, hi everyone. Welcome to today's meeting. Today we have a spine surgeon, Dr. Andrew Chung, talking with us today, and um, he can just get started whenever you feel like it.
Hey, thanks guys for putting this together and for hanging out with me tonight. Um, I was just telling Anisha that I don't look very official because we literally just moved into our home in Phoenix. I've been painting all day, so sorry I'm not like in a cool office or wearing scrubs or something. But I promise you um, that I'm a real doctor and I do doctor things. So what I wanted to do is just kind of talk to you guys about, um, what a spine surgeon does, and then just kind of go through kind of a generic schedule of what life as a spine surgeon looks like. Um, Give you some shots of what the OR looks like, and then the operating room that is, and then just take questions. Whatever questions you guys may have, don't be shy, ask away, and happy to answer anything. So we'll just get started here. So Sonoran Spine is the spine practice that I'm a part of, and we're based in Phoenix, and kind of Phoenix area, metropolitan area in Arizona. So who am I? I'm a double fellowship trained orthopedic spine surgeon. I kind of have an interesting course to medicine. I went to Texas Chiropractic College. Actually, was interested for a little while in pursuing chiropractic, and then kind of as a result of my background, long story short, ended up going to an osteopathic medical school. For those of you that aren't aware, physicians nowadays, there's kind of two routes. There's the traditional MD route, and then DO or osteopathic route. And the end product is essentially the same. Um, you know, I'm a surgeon, I'm a DO. You can pretty much go into any specialty as a DO. And so you may have seen docs in your own care or maybe in family members' care, and they may have been DOs, and you may not have even known that. Ultimately, I did my residency at the Mayo Clinic in Arizona, just right local to where I've moved back to, and part of the reason why I'm back. And I did my residency in orthopedic surgery. I won't really go too much into orthopedics in the talk, but just to kind of give you a general overview of what orthopedic surgery is about. Probably one of the coolest specialties. Obviously, I'm biased, but you deal with broken bones, you fix them. If somebody's got a worn out hip or knee or shoulder, you can replace them with a prosthetic um, um, or artificial joints. Um, do like limb deformity correction in pediatric patients. So you have some kiddos that are kind of born with odd shaped limbs, or perhaps limbs that are maybe a little bit malformed, and you can actually kind of help make them normal again. So that's all part of the scope of orthopedic surgery, and then including spine surgery as well. And most of us, we end up kind of subspecializing in an aspect of orthopedic surgery. There are a few kind of generalists nowadays, meaning somebody that'll go out into the community and they'll just kind of do everything under the sun in orthopedics, but that's getting more and more rare. And particularly in big cities, you have to be fellowship trained. And so my fellowship training was specifically in spine surgery. And the way that works is basically, once I'm done with my 5 years of orthopedic surgery residency after medical school, I go and basically hang out and learn from spine surgeons and just do spine for a year. Um, and so I did my spine surgery training with both neurosurgeons and orthopedic spine surgeons at the University of Southern California. And then this is a little outdated. I actually just finished an advanced fellowship in some more advanced spine techniques at Cedars Sinai and Doc's Hospital in LA and Beverly Hills. And then I moved back to Phoenix to get started in practice here. So, some people don't really know, but there's actually, two paths to becoming a spine surgeon. So you can take the better one, which is the one I took, which is orthopedic surgery to spine. And then you can see there the kind of the years required in order to become a spine surgeon. And at that point, you're a fellowship trained spine surgeon, and you can go out and operate on people. The other route, which honestly is just as good, you can go the neurosurgical route. And so in neurosurgery residency, they tend to be longer, and they mainly work, obviously on the brain, but pretty much brain and spine. So by the end of their 7 or 8 year residency, most of these guys can come out and do spine surgery pretty competently without a year of spine fellowship training. That being said, academics, a lot of hospitals are starting to require an additional year of spine fellowship training because they want fellowship trained spine surgeons. And so you're really looking at a very long route to spine surgery if you go the neurosurgical route. Really, at the end of the day, the end product is pretty identical. If you can kind of go back into the history of what orthopedic spine did versus neurosurgical spine. Neurosurgical spine typically worked around the nerves, whereas the orthopedic surgeons were the ones doing what's called a fusion of the spine, or correcting deformities. Meaning if you've got, you may have heard of something called scoliosis, where the spine is kind of S-shaped. Orthopedic surgeons were typically the ones to kind of straighten that out. They were the first ones to put hardware into the spine. So, rods, screws, things like that. Whereas the neurosurgeons, again, just kind of worked around the nerves and did what are called like decompressions, kind of dealt with disc herniations, things like that. I realize I'm throwing a lot of terms out. So if you guys have any questions at the end, please feel free to ask. But over the last, 20, 25 years, really the specialties have kind of merged. And so when you go to like the big spine societies, so every kind of physician group, or even like nursing group or whatever, they kind of have their own little kind of clubs that they hang out in. And so spine surgeons kind of have their own clubs too. And the guys that, kind of lead these clubs are both neurosurgeons and orthopedic spine surgeons. So really at the end of the day, it's kind of what you decide you want to do with your background training. But spine surgeons, as long as you're fellowship trained, you're pretty much the same thing at the end of the day, whether you're a neurosurgeon or an orthopedic surgeon. So what do spine surgeons do? Well, as you might suspect, we treat spine conditions. So we both operate and treat patients with spine conditions non-operatively. And in fact, we probably do more of this. I would say, depending on your clinic, maybe 10% of patients actually need surgery, and oftentimes even less. And so a lot of that is just kind of us recognizing that, really this patient doesn't need surgery. Maybe all they need is physical therapy or some pain medication or something like that. So probably the most common thing that we do deal with, though, is arthritis of the neck and the back. So arthritis just kind of being wear and tear of the joints in the spine. Believe it or not, there are joints. And there's actually something called a disc. And we have multiple discs in the spine. And they're basically like shock absorbers. And they exist between each of the little bones in the spine. And basically, these discs can kind of wear out with time. And there are other things that can kind of cause them to wear out. But when they wear out, that essentially is what we call arthritis in the neck or the back. Whereas you guys may have heard of arthritis like in the joints, like in the hip or the knee or the fingers. That's a little bit different in that, when you look at a joint, you basically have two bones. Like if you're talking about a hip joint, got a ball and ball in a socket, and on the end of each one of these bones, you've got the smooth cartilage, and that cartilage is what allows for a nice smooth motion of that joint. Now, when that cartilage wears down, with time, or there are other kind of things that can cause it to wear out faster, but typically it's just kind of wear and tear, just like tires on a, treads on a tire, wear out as you drive a car more and more. So does that cartilage. And we call that wear and tear of that cartilage arthritis. So the equivalent of the disc wearing out in the spine is, in the joints, is the cartilage wearing out in the joints. So long and short of, what arthritis is in the neck and the back. Disc herniations. So again, those little shock absorbers, they actually are kind of like jelly donuts. They've got this gelatinous material in the center of them. And that actually gives it that shock absorption ability. And that kind of jelly material can actually, what we call herniate out the back. And behind that disc, kind of housed within the spine, is the nerves. And at the level of the neck is actually your spinal cord, which is basically like, a direct extension of your brain. And so you can imagine if that disc herniates and pinches on your spinal cord, that's a problem. Or if it pinches on a nerve, that's a problem. Because the spinal cord and the nerves that controls, various parts of the body. Spinal cord pretty much at the level of the neck controls everything from the neck down, our ability to move our arms, feel our arms, move our legs, even go to the bathroom. So when somebody's got a bad disc herniation in the neck and it's pinching on the spinal cord, that's a bad problem. More commonly, though, we see disc herniations in the low back. And in the low back, by that point, it's the nervous system is not spinal cord. It's more of these individual nerves, and they're like electrical wires, and they basically go out and they allow us to feel or move certain parts of our body. And so if you get a disc herniation in the low back, which is, again, the most common place that we see these, it can cause pretty significant pain in the area that nerve allows you to feel. And it can even cause weakness in, that group of muscles that nerve kind of gives electrical input to. And so disc herniations can be a problem. And so those are things that we also kind of deal with as well. Spinal deformities. So again, I kind of mentioned scoliosis. So this is an example of a scoliosis, like an S-shaped curve to the spine. If need be, these can be straightened out, and you can kind of see an example of that there. And it's cool. We use, screws. We literally put screws into the spine. And you can imagine that can be potentially dangerous because there are some pretty important structures there. And then we connect them all with rods to kind of straighten out the spine. And so that's a spinal deformity correction, is what we call that. Trauma. So if somebody falls or gets into like a car crash or something like that, they can actually break the bones in their spine. And in some cases, we need to fix that, and we need to stabilize that spine. Just like if you broke your arm or something like that, in some cases we need to fix it, with some plate and screws in the arm, that is. So same thing in the spine. Tumors. Sometimes you get some tumors in the spine. Obviously not as common as these other things, but certainly can happen, and we address those as well. What's going on there? So what do I love about spine surgery? Well, anatomy's cool. You look at the anatomy of a spine, like on a model, and you're like, man, it's really not much, right? It just looks like just looks like a spine. But really, the anatomy is so just intriguing. Every millimeter counts in the spine, and it's not just the spine; it's everything that kind of surrounds it. So, for instance, when you're operating on the low back, as you're putting screws into the spine, right in front of that spine is your big vessels, your aorta and what's called the inferior vena cava. And so if your screw goes too deep, you can literally, kill that patient. So you really have to be very careful about, what you're doing. And again, the anatomy is, you just have to be super precise with what you're doing. And again, the anatomy that you're dealing with is just, to me, because of that, very fascinating, because you just have to know exactly where you are when you're doing these surgeries. Whereas in some of the other orthopedic professions, you can kind of be off a little bit, and it's fine. But in spine, you don't want to be off. Clinic, most people go into surgery because they like surgery. They don't like clinic. Imagine that. But in my opinion, if I'm going to be doing something, or if I'm required to be in clinic, then I want to enjoy it. And to me, spine surgery clinic is awesome. Every patient that comes in, not only is it cool just to kind of interact with patients, but you really get to do that in any specialty. But what's most interesting and fascinating to me about spine surgery clinic is every patient is a little bit of a puzzle. And the reason why I say that is because um, I mentioned that each one of these nerves that kind of controls our legs and our arms, it's basically like they're like electrical wires, right? And so if they get pinched at a certain point in the spine, then you can have pain. For instance, like let's say you pinch we call like the L5 nerve, which is in the low back. Got a disc herniation, it pinches that nerve. That's going to cause pain on the outer side of the calf, and then kind of down onto the foot. Now, there are a lot of issues that you can have in the leg itself or in the foot itself, that can also cause that type of pain or pain in that area as well. And so you kind of have to, be careful about, what you're actually treating. And so it's not like clear cut. It's not like, somebody comes in, they've got pain and in a certain part of the body, and then all of a sudden exactly what to do. You really have to be able to kind of figure these puzzles out. And to me, that's very interesting. That what we call like a diagnostic. It's a diagnostic challenge. Just figuring out oftentimes what these patients have can be, a little bit of a puzzle. And to me, that's interesting. Um, Obviously surgery is cool, and spine surgery again is very fascinating, particularly because of the anatomy that you're dealing with, but also the technology nowadays that we're able to kind of employ or use in surgery. And so whereas before, with traditional spine surgery, and actually still 60-70% of people do what we call traditional open surgery. Literally, you would just fillet open the back, right, straight down the middle, open up all the spinal elements, and then kind of do your surgery that way. Now, with these kind of what we call minimally invasive techniques, you can literally access the spine through, 10 millimeter or even 20 millimeter incisions, to kind of accomplish the same thing. So you can kind of see an example of that in Figure E there, where those surgeons are working down these small tubes to ultimately get down to the spine and address the issue that needs to be addressed. In the past, again, that would be a big, midline open incision, and so we've really come a long way. The other thing about spine surgery that I really like is that you really, just like in orthopedics, when a patient comes in, they've got a bad hip, they can't walk. You take them to surgery, 2-hour surgery or less. You replace their joint. That day they're up and walking, and they haven't been able to do that in like years. And so you're really affecting people's function, and that's what I love so much about orthopedic surgery. Spine surgery, it's the same thing. You have patients that come in, they've got disc herniations causing extreme pain in their leg or in their arm. They can't work. Maybe they have weakness, even they can't walk or they can't use their arm. And you go in there, you take them into surgery, and you fix that. And that day, even they're able to kind of get back to at least many of the things that they weren't able to do, and a lot of their pain is already gone. And so being able to have that privilege, I think is an amazing thing. And so again, another reason why I like spine surgery so much. And the future is bright. Again, technology is just, I mean, it's like skyrocketing in spine. Like literally in the last 10, 15 years, I mean, the technology that we have in spine surgery has really just kind of exponentially grown. And so now we've got robots, and we've got computer navigation, and all sorts of things to kind of help people out, and more is coming down the road. We're really just getting started in spine, and so the future is bright. By the time you guys kind of get here, I'm sure things are going to be just incredibly fascinating. So just to kind of go through, what schedule typically looks like for a spine surgeon. And this is loose because every spine surgeon really kind of makes their own schedule, and it kind of depends on what we call practice setting you're in. Meaning, if you're employed by a hospital, they may set your schedule. If you work in academics, kind of the same thing. Or if you're private practice, meaning you're kind of your own boss, then you may set your own schedule. So this is just, again, kind of a loose schedule of what it might look like. Um, may be like, through 2 to 3 days of operating room time where you go and you actually do the surgeries, and then 2 to 3 days of clinic where you see patients in clinic. You evaluate them to figure out if they need surgery or not, or whatever treatment they need. And then you'll also, obviously, follow up on patients that have had surgery and make sure they're doing okay. Weekends, typically, if you have patients in the hospital, you'll go around and what we call round on them. So you'll go and see them and make sure they're doing okay. Again, kind of depends on your practice model. If you're in academics, you may have residents doing this for you. In private practice, you may have the PA doing it for you. I think it's just good practice if you're a surgeon and you've operated on a patient, unless you have somewhere like truly very important to be, you probably should see your own patients. So at least for me, I would round up my own patients. Um, Call. This really depends on, again, kind of what you want. And so it's not like every spine surgeon does the same thing, has the same schedule. It really kind of depends on, what they want with their, career, and again, the practice model, meaning, are they employed? Is a hospital kind of tell them what to do, and they kind of listen to the hospital, or are they private practice, like myself, where I can kind of decide for myself what I want to do? So, for instance, I won't be necessarily taking any call, but some of my buddies that are in different employed settings, they take call, and what that means is that once they're done working for the day, they're kind of still on the hook. So somebody can call them and be like, hey, we got this guy in the emergency room. He's got a spine problem. I think he may need surgery tonight. Can you come see him? That kind of thing. So that's where the life of a doctor starts to get, or a surgeon starts to get kind of potentially exhausting. So for me, I didn't want that. So again, that's kind of up to what you want with your life. Inside the OR, here's some pictures of the OR. That's me in the back, in the light blue, pretending to be important, but really nobody's listening to me. And just a few things. This is a cool thing that we call a C-arm. It's basically intraoperative X-ray. It allows us to kind of see the spine, like an X-ray right in the OR. And in spine surgery, at least traditionally, it's been very important to kind of figure out where you are, right? So it's not like the knee or the hip where you've got one on the right side and you've got one on the left, and you really can't miss it. If you miss it, you probably shouldn't be operating. In the spine, you've got so many segments, and so it is hard to miss, to kind of be at the wrong level if you're not very careful. And so that's why we use X-ray to kind of help us figure out where we are. And then when we're putting implants in, metal and screws and things like that, the C-arm can kind of give us a little bit more guidance about where we are in space. Because if you can imagine, you're only able to look at the spine from the back, and so you don't see where your implant is front, back. You really have to either have a good feel for it, or use X-ray. Just a bunch of monitors around the room. Here's the patient. He's lying what we call prone or face down. We've kind of draped off the area that we'll be operating on, and clearly here there's no blue drape, so this is kind of before all the sterile drapes go down. Anesthesia's over here. You can kind of see this tube. This is a ventilation tube going to the patient. So he's been intubated, and he's being mechanically ventilated so that we can operate on him. Just another few pictures. This is the nurse. She's about to prep the back, meaning just kind of scrub it, kind of clean it off. Here's some OR lights. For this case, we were using the robot, and so you can kind of see some of that technology there. This was not the same case, but just to kind of give you an idea, before every surgery, you got to scrub, right? You got to clean those hands, get the bugs off. get the poo off. If you've gone number 2, right, you got to get your hands clean. So this is how you do it. Traditionally, you do it with a scrub brush. So it's a soap, and basically what it sounds like, a scrub brush, and you just kind of scrub your fingers and hands all the way up to your elbows. Now, more people will use what's called a gel. It's basically antiseptic gel. You'll just kind of spread over your hands, and that's just as good. I'm wearing loops. This allows me to see a little bit closer. And then a headlamp, because oftentimes, again, particularly when you're doing minimally invasive surgery, you're working through a small tube, and it's like trying to look down a small dark hole. You need some light, focused light. Just some pictures. Sorry, there's a little bit of blood here, so if you're squeamish, just turn away for a little bit. I'll tell you when to look back. But this is just some pictures of what the robot looks like, and this thing I'm holding, believe it or not, it's an actual drill. So it's just like you drill holes into wood. We're literally drilling holes into the spine, and we're going to put some screws in there. So this is the kind of stuff that we do. Just to kind of give you some of the other, an idea of some of the other tools that we use. So we can use loops, again, to kind of look a little bit more closely, but they typically only magnify, at least the ones we use in spine surgery, maybe 2.5 times to maybe 3.5, 4 times normal. With the microscope, you can really magnify or get a higher magnification of what you're looking at, and it kind of focuses, the light to exactly where you're looking at. So we're really trying to get, working in delicate structures, or really trying to get a fine view of what it is that we're working on. We can potentially use the microscope, which is to the left. Some people just don't like using loops, so they'll use the microscope, and vice versa. Here to the right, this is us getting set up for CT navigation. So just like we can use a robot to kind of help guide us, prior to the robot, oftentimes what people would use and still use is what's called computer navigation. And so basically what you do is you set up a sensor on the patient's body, and you actually drill it into the bone. And then you get intraoperative CT. CT is computed tomography. It's a 3-dimensional, basically X-ray. And so you get the CT in there. It basically takes a scan of the patient. And then we have these tools that are calibrated to the navigation kind of system. And we can know exactly where we are in space on that patient with that system. So that's kind of what 3D navigation is. A little bit of blood here, so turn away if you want to. Again, I just kind of wanted to give you a sense of the size of the holes that we're kind of working through sometimes, and that's more of the minimally invasive approach. Again, traditionally it was kind of big midline approach to kind of get things done, and so technology really has come a long way, and it continues to advance. So you can see here, this is probably like a 24 millimeter incision, so a very small incision, and you're drilling away bone, and just to kind of give you a sense of how small of a space we're working in. You can kind of see the finger is almost taking up that entire hole, and you're working through there to ultimately do the work that you need to do. In this case, we were basically taking away some arthritis that was pinching on the nerves, and then we were going to fuse the spine. And so we were doing that through 2 very small incisions, whereas again, before it would be one much bigger incision. So that's all I really got for you. Hopefully it gives you a little bit of sense of, what spine surgeons do, and, maybe we can be colleagues one day, and it'd be cool if you told me that, it was me that got you interested. But hey, thanks for hanging out. If you guys have any questions, happy to answer any questions. So yeah.
How did you start your own practice?
It's a good question. I'm still figuring it out. No, it's it's just like any other business owner, and honestly, it's becoming more and more difficult to start your own practice. So the days of truly being in like independent, private practice, meaning like your own guy or gal, doing your own thing, it's getting harder and harder. And the reason is because insurance companies are paying you much less. Hospitals are kind of doing everything to prevent you from doing that, unfortunately. Um, and because they've kind of set up referral systems, right? So you've got big hospitals that basically have these networks of people that, refer to each other, meaning like if I'm a spine surgeon, I ultimately need, primary care doctors to send me patients, right? And, otherwise it's really hard to build a practice if I'm not getting patients. And so if you've got a big hospital system that's got, that hires hundreds of primary care physicians, then those guys are gonna and gals are gonna, refer only to the spine surgeons within that hospital system, most likely. And so it's hard to compete with that. And the reason why, it's just like any other business. If you're not getting paid enough, you can't afford to, hire, and pay for the people that you need to essentially practice independently, pay for the lights overhead, that kind of thing. And so it's becoming more and more rare for people to be in their own true independent practice. And so, I don't know that I know many people that are doing that. There's a few, but it's really hard to do. And a lot of it is that, these people are okay with making less money than they really are entitled to, in exchange for really just being their own boss, right? Like to them, what's most important is that they call the shots on everything. And so they're willing to kind of sacrifice, making less money for that. And unfortunately, you got to get paid, right? Like, unless you're coming from, significant wealth, it's hard to, do what you do and not get paid for what you do. And so that ultimately drives a lot of the decision making as to what type of practice model you go into. That being said, there still are private practices. So, but what they're more groups of people that are kind of, sharing, the costs of keeping the lights on and the secretaries and things like that. So that's the type of private practice that I'm joining. And so, you can definitely do that. You get enough people together that want to do that, and you slowly grow. You can definitely create that. But part of that is just being a good business person as well. And you know, it's a good thing that it's really a good thing that you bring up is we really don't learn that in any of our training. And so I would encourage you guys, if you are going into medicine, really anything, um, you know, try to learn uh, just at least the fundamentals of like business management and marketing and things like that, because I think those are skills that are just going to be beneficial to you regardless of what you know walk of life you ultimately end up in. So long answer to your question, but hopefully uh, it answers your question.
What's the most interesting case that you've encountered?
Um, you know, I feel like I have a different answer every time somebody asks me that. I think probably the most rewarding cases are like the pediatric cases, where you have kids come in and they've got significant deformity. They're kind of hunched over, or they can't and they can't stand up straight, or their limbs are malformed, and you go in there and you get them to grow longer and you fix them. I think that those are pretty significantly impactful cases. An adult, I did a case last year in a patient who basically had what's called dropped head syndrome. And so basically her head was like this and she couldn't look up. And so literally, you see her and she looks at you, like looking upwards. And imagine living like that, for, day in, day out. And yeah, so we operated on her and we straightened out her neck, and she loved it. Just being able to look forward, I mean, that was just super. I mean, it was just like an honor to be able to do that for her, and so that was pretty impactful as well. But honestly, everything that we do is pretty cool. So there's a question in here: how difficult is it to do well in pre-med? You know, I think I think it depends on you, right? I mean, there are some people that make it look really easy, you know, unfortunately, you know, and that can be frustrating for some because, you know, you're going to see that, and maybe you'll be one of those people. I don't know. It's quite possible, and good for you if you are. But you know, most people, you know, they've got to work hard to do well, and I would just encourage you guys to do that. If this is what you really want to do, then make sure you put the effort in, and don't be discouraged if you know you see people that aren't working as hard. You know, it's just the way it is. You may have some other skills that they don't have, and they look at you and they're like, man, you know, I wish I had that. And just remember that, you know, that that's just life. What do you? There's another question here. What did you do or recommend doing in high school to have a successful path to a surgeon? You know, if I can be completely transparent with you guys, I really didn't know what I wanted to do for a while, which is why I ended up in chiropractic school. So I didn't have the best grades, mainly because I just enjoyed, you know, playing around a little bit too much when I was younger. I wasn't smart like you guys, and didn't have my act together early on. You know, but you know that was okay. It turned out fine, right? But you know, I think you know when I give you guys, if I were to give you guys advice on you know what to do and um, you know, be successful ultimately as a surgeon or whatever it is that you guys want to do, I would say try to do everything you can to be well balanced. So you know, studying is good. You know, obviously you need the grades, you need the knowledge, but more importantly, I think what really makes um, the the great doctors great is not necessarily how much they know, because you'll get there. If you've got a brain, you can learn, you know, whatever it is you need to learn. The things that you really can't learn quickly are like life skills, like you know how to be sociable, you know, how to talk to patients, um, you know, like business skills, right? Like things like that. Um, you know, appreciating you know what it's like for you know people who are you know socioeconomically disadvantaged, you know, appreciating people from all walks of life. Not everybody gets that, you know. There's a lot of people who really just kind of do everything right, and they go from one great school to the next, to the next, to the next, and all they're exposed to is just that, and they're only exposed to people like them, and they never really get to see the real world and experience the real world. And I think that that's a mistake. So not to say that there's anything wrong with going that path, but if you are going that path, just make sure you make some time to just kind of develop yourself outside of just academics. I don't know if that makes sense, but I really do think that that is the key to becoming a great doctor, because you know, again, you'll see it. You get to medical school, you get to residency. As long as you have a brain, you're going to learn the things you need to know, and you're going to have to work very hard to do that. But to develop those types of skills concomitantly while you're working your you know your ass off in residency and medical school, it's hard. So do it now. You know. Any other questions?
How did you decide that you wanted to do spine surgery over like any other field?
Um, so my wife likes to think it's because she had spine surgery in the past, and that motivated me to become a spine surgeon. Honestly, it was kind of a mix of you know experiences. I started out in chiropractic school, again mainly because I just didn't know what I wanted to do. But in chiropractic, I don't know if you guys are familiar with it, but you really do focus on the spine. And so, you know, I learned, you know, basic anatomy of the spine, and I found it fascinating. Basic neuroanatomy, found it fascinating. And then once I decided I wanted to pursue medical school, then I wanted to do more. I started shadowing spine surgeons because I really loved. I was fortunate because my chiropractic school actually had an anatomy lab where you go in and you dissect cadavers. And I really enjoyed that aspect of it, the anatomy, the anatomical dissections. And so I was like, well, I like the spine. I also like, the anatomy, and I like dissecting the anatomy. Well, naturally, spine surgery makes sense. So I went and shadowed some spine surgeons and just really enjoyed what I saw. And again, it was kind of that mixture of things that I kind of talked about that to me are fascinating about spine surgery, right? Clinic is cool. The surgeries are cool. The amount of impact you can have on your patients is just, it's tremendous. And to me, it's just it's a tremendous honor to be able to do what I do, and to have patients who are actually, letting me do that to them. So. Anything else, guys? Well, I would say, here's one. Do you have to really like the sciences to become a doctor? I think yes and no. I mean, there's a lot of science to be learned, especially, in undergrad. If you're pre-med, you just, it's like the check boxes, right? You got to do it. Now, do you have to actually like it? Probably not. But it helps, right? Anything you can do, kind of a learning tip. Anything you can do to make something enjoyable, whether it's being like, hey, I absolutely need this to become a doctor, and I want to become a doctor. So this is a necessary evil. So I'm going to do everything I can to just kind of reorient my mind to make this enjoyable so that I can achieve that goal. Or if it's truly like, man, I love organic chemistry, which if that's true, maybe you should just become an organic chemist, because I didn't like it. But yes, you do have to enjoy the sciences, mainly because it's required of you to become a doctor in one shape or another. You got to pass the classes, you got to get the grades, and unfortunately, they're kind of unnecessary or necessary evils. Now, once you become a surgeon or whatever it is that you decide to become, do I need to know organic, the organic chemistry of every I don't know, natural gas on the planet like that? No, I don't need to know any of that. But I needed to know it at one point to get where I'm at. My major was my major was human biology, and the question is would you change it if you could do it again? Yeah, I think so. I think again, I appreciate so much just the necessity that there is for people just in general, whether you're a doctor or not, to be well balanced. And so you're going to get enough human biology as you move forward through medical school. Now, is majoring in an undergrad going to help you understand it better in medical school? Yeah, but there are a lot of things that I learned in medical school that I learned for the first time, and it was fine. So I think if I could do it over again, I'd probably pick something that I felt like I really wouldn't get out of medical school, and then just kind of do the pre-med requirements. Now, don't take my advice though. Do what makes the most sense for you, and what makes the most sense for whatever medical schools you want to go to. Do what makes the most sense for you. Another question: do you have any tips on maintaining a good work-life balance? Yes. Do it. It's hard, I mean, it's easy to get carried away in what you're doing. I mean, my sense is that if you're in this club at your age, you guys are kind of type A and want to work hard and want to be successful, and there's nothing wrong with that. But I can tell you that I've met a lot of famous spine surgeons that their biggest advice to me always is, hey, enjoy your family, like enjoy your friends, because those are things really at the end of the day that matter. And so as far as maintaining good work-life balance, I think it's just kind of keeping that in mind, understanding that it's important, and then trying to schedule some time in whenever you can. It's hard sometimes. Like in residency, I would work, 36-hour shifts on, and then you'd sleep for like, 5, 6 hours, and you're back at it, and sometimes you're working 110 hours a week, and it's hard to maintain that. But, it's not always like that. And then, so when it's not, you make sure that you do spend some time and schedule some time to kind of, do what you need to do. Now, most schedules are not 110 hours a day. So I think for most of us, even though you're busy, working 12, let's say 14 hours a day, you can still, make sure that you schedule 30 minutes or 45 minutes or even an hour. And then maybe, half a day on the weekend on, yourself. And then, on family and friends, so just schedule it, just kind of keep it in mind. The fact that you're kind of keeping it in mind, I think, to me, will make it a lot easier for you to maintain that type of balance. How do you prepare for the ACT, SAT? Man, that's so long ago. I think my mom made me take a bunch of, SAT classes, and I mean, that's, just just soak up the knowledge, and do, just like any other, practice or any other exam. I mean, you guys are, if you're going into med school, you guys are on your way to, just becoming experts at standardized tests. And really, the best way to get good at standardized tests is to use the test prep material and just do as many questions as possible. And I don't know that I can give you more than that because it's been so long for me. Do you have any tips for studying biochem if it doesn't come to me, even if I study for many hours? Yeah, I think, studying in groups, getting the extra help early, to truly understand it. And there's going to be classes where, you just get like that. Um, and others where it's just like, it's just not intuitive, right? Like some people are more visual. Some people can, learn well by, just kind of reading it off the page. Um, everybody, learns a little bit differently. And so you just have to continue experimenting with ways to study that, you ultimately will find, work for you. And whether that's studying with a group, because other people can kind of give you their perspective, or, just identifying early that it's going to be difficult for you. And so just constantly getting extra help early on. Yeah, I mean, you don't feel discouraged if there are classes that you see your peers doing really well in and having an easy time with, and you're struggling a little bit more. It's going to come back around. There's going to be things that you're going to have some strengths that, other people don't have. So don't ever feel discouraged about it. But know that, you're going to have to put the extra work in, and that's okay. All right, guys. Well, I got to run. I appreciate you guys for hanging out with me tonight. Again, if you guys have any questions about anything, feel free to reach out to me on, I think the only real social media I'm on is Instagram. And yeah, happy to answer any questions, or if you guys want to, shadow or anything like that, let me know.
Thank you so much.
Thank you.
We're going to be
Thank you.
having his Instagram and the email will send out soon, so you can reach out to him if you have any questions. But thank you so much